Subscribe now and press the bell icon. Never miss an update.
Session on hepatobiliary system. So today's topic of discussion is gallstone disease. So the gallstone terminology is cholelithiasis. So before starting the disease process, firstly we discuss to some extent about the anatomy of the hepatobiliary system. So look the picture at the side. The gallbladder image is there. The gallbladder is a pair or globular shaped organ. Pair or globular shaped organ. It's located right hypochondrium in inferior surface of the liver in gallbladder fossa. That means it present on the right upper abdomen. So the location, anatomical location, everybody must remember, because otherwise if you don't know the anatomical side, you don't able to diagnose the previous disease process. For that reason, the location everybody must know. It lies in the right hypochondrium in inferior of the liver or in the gallbladder fossa. The parts are, it is fundus. This is fundus. This is the fundus. Free part of the gallbladder, rounded one, is called the fundus. Then it is a body, and there is a neck. The neck is connected with the rest of the biliary tree, which is called the cystic duct. So there is a fundus, a body, neck. Then it is connected with the biliary tree by the duct, is called the cystic duct. So this is about the gallbladder. And very important thing is, in the neck, there is an outpouching of the gallbladder, which is called the Hartmann's pouch. It means outpouching at the junction between the neck and the cystic duct. Between the neck and the cystic duct, the outpouching part is called the Hartmann's pouch. And the gallbladder drains through the cystic duct, which joins with the common hepatic duct to form the common bile duct. This is the cystic duct, and this is the common hepatic duct. Meeting together form a single duct is called the common bile duct. So that means the common hepatic duct is formed by the right hepatic duct and the left hepatic duct. This right and left hepatic duct drain the bile from the liver to the common hepatic duct. And subsequently the bile is passing down, go into the common bile duct. And from the junction, the bile is go inside the gallbladder and rest in the gallbladder. And in the resting time, the bile is accumulated in the gallbladder, and gradually the gallbladder is distended. For that reason, in fasting state, the gallbladder do the investigation of ultrasonography, the gallbladder can easily visualized. And the bile is passing through the common bile duct, joined together with the pancreatic duct, and drain into the ampulla of beta in the second part of the duodenum. In the medial surface aspect of the second part of the duodenum, the biliary tree is drained. That means the ampulla of beta lies at the second part of the duodenum. So the gallbladder drains through the cystic duct, which joins with common hepatic duct to form the common bile duct. In other words, the bulb of Hister is produced as functional bulb due to the contraction of the gallbladder. Look at the picture. There is mucosal fold is there, which is called the bulb of Hister. So now with the gallbladder anatomy discussion, we discuss very important triangle, which is very important for surgical dissection of the excision of the gallbladder. At that time, we very cautious about the Kellogg's triangle. That Kellogg's triangle, everybody must know the anatomical location of the Kellogg's triangle and how can you identify it and what are the contents of the triangle is. So, which is called the, also known as the cystohepatic or cystobiliary triangle, which is named is the Kellogg's triangle, or hepatocystic, that means hepatocystic triangle. So that it is important landmark to identify the cystic duct and cystic artery during cholecystectomy. So importance is, during cholecystectomy, the cystic duct and cystic artery are located at that triangle. For that reason, that is the very important one to know everybody. This is Kellogg's triangle. So the boundary of the Kellogg's triangle is above. So look, if you make a triangle like that manner, above there is the liver, and below there is the cystic duct, and medially it is the common hepatic duct. This is common hepatic duct. So the triangle is called the Kellogg's triangle. So within the Kellogg's triangle, the contents are, this is the cystic artery, and this is part of the right hepatic artery, sometimes may there. And with the artery, always there is a lymph node. The lymph node name is lymph node of Laurent. So the important structure is cystic artery and lymph node. It is very close relation to each other. Over the artery, there is a lymph node. It drains the lymphatics from the gallbladder to that node. For that reason, the name of the lymph node is lymph node of Laurent. And during laparoscopic cholecystectomy, the lymph node dissection of the cystic artery, the lymph node there. So whenever you identify the lymph node, always be cautious about that. You can reach near the artery. Nowadays, the safety of operation is a very important tool. So everybody do the surgery with a documentation that there is no injury during the operation. For that reason, nowadays there is more emphasis given towards the dissection of the Kellogg's triangle during cholecystectomy. That means the terminology is called critical view of safety. Nowadays is very frequently asked in the exam and frequently given in the written short note, CVS, critical view of safety. That means during cholecystectomy, the gallbladder is attached with the liver with a peritoneal reflection over there. So the Kellogg's triangle is covered by a peritoneal fold, anteriorly and posteriorly. There is a peritoneal fold. Within the fold, that cystic artery and the cystic duct lies. So during operation, during dissection of the Kellogg's triangle, you dissect that gap and that gap. Remove the peritoneal reflections, remove all the loose relay tissues, and look, there is only two structure lies within the triangle. That means one is cystic duct and another cystic artery. This takes a picture during operation, and this is documentation that during operation you don't do any sorts of injury there. It is that reason the name of the view is called the critical view of safety. That means within the Kellogg's triangle, you look, there is a cystic artery, and in Laurent, only a tubular structure which is a cystic duct. If there is more than this, then you may confuse that there may be an accessory duct, or there may be right hepatic duct, there may be accessory cholecystohepatic duct or accessory arteries, or that lies there. You be cautious about it. For that reason, the Kellogg's view, critical view of safety, is very important to know for the dissection and during the operation of cholecystectomy. So these are about the Kellogg's triangle. which nowadays it is called, don't say about the Kellogg's triangle. Nowadays it is called the hepatocystic triangle. Hepatocystic triangle. That means this cystic, this liver, and this the common hepatic duct. So after that, we discuss about the cholecystitis, because the gallbladder having a disease of the stones formation. This is one of the disease. The another of the disease is called the cholecystitis. That cholecystitis having two varieties. That means inflammation of the gallbladder, which is called the cholecystitis. Acute inflammation is called the acute cholecystitis. Chronic inflammation is called the chronic cholecystitis. But that two cholecystitis having two types. One is the cholecystitis is produced along with the stone. That means it is called the calculous cholecystitis. Acute calculous cholecystitis. Whenever there is no stone, only there is infection, inflammation, then it is called acalculous cholecystitis. That means the gallbladder is inflamed without any stone inside the gallbladder. So it is called the acalculous cholecystitis. So one is calculous one, another is acalculous one. So look the picture. This is the gallbladder, and which is attached with the underlying structures of the stomach and duodenum. There is some fiber-like adhesion, fibrinous adhesion there. So this indicates there is a inflammation, because whenever an inflammation, there is exudations. So there's exudations having the formation of fibrin threads. So the movements of the gallbladder during a movement, lying, standing, walking, etc. So all the time the viscera moves. So that moves, causing the filmy adhesion between the gallbladder and the livers and the diaphragm. That becomes to pull each other, and the fibrinous exudate become presented as a thread-like manner. But if in a normal gallbladder there is no infection, no inflammation, at that time there is no adhesion with the surrounding structures. Whenever you look laparoscopically, very clean gallbladder, there is no like fibrinous thread scenes between the gallbladder with the liver, with the stomach, duodenum, colon, etc. in the surrounding viscera. So whenever after introduce the laparoscope, look, there is a filmy adhesion there. It is the proof that they are having some inflammation previously. So these are about the cholecystitis. Next, about the gallstones. So in the gallbladder stones, there are three types of stones formed within the gallbladder. The types are cholesterol stones, mixed stones, and pigment stones. Important one. So the cholesterol stones, which is only 6% individual, can carry the cholesterol stones. Usually single, has radiating crystals-like appearance over the surface. So single gallstones, usually we think that it is cholesterol stones. The mixed type stones, 90% is a common stone, is a mixed type, which are the most common and usually multiple in number. And it composed of cholesterol, bile acid, pigment, calcium salt, or phosphate, carbonate, palmitate. Usually they are multiple and faceted. So our external appearance is the multiple faceted stones within the gallbladder. It is mixed stone. Always remember, single rounded stones within the gallbladder, it is most likely it is a cholesterol stones. The others are pigment stones. So they are brown or black. Two types of pigment stones are formed within the gallbladder. So these stones, some are brown, some are black. The brown pigment stones, it composed of cholesterol, calcium bilirubinate, calcium stearate, and calcium palmitate. And black pigment stone composed of cholesterol, bile salt, calcium bicarbonate, calcium phosphate. So these are the composition which are diagnosed by biochemical analysis after removing the stones. Otherwise, it is not possible to know what type of composition of the stones are. The composition are evaluated after send the stones to the laboratory for biochemical analysis. Then they can say that this is the composition of the stones are. So for your exams, you only know the three terminologies sufficient: cholesterol stones, mixed stones, and pigment stones. Here your basic knowledge is required. Single stones is usually cholesterol one, multiple faceted one is the mixed stones, and multiple black or brown color stones are usually pigment stones. So these are the three types of stones. By morphological appearance, you can evaluate what type of the stones are. So look at the pictures. This is the cholesterol stones, single rounded and radiating over the surface. These are the faceted, just like a soccer. So first one stone form, then another stone form. So one another make a pressure effect there. For that reason, they take the shapes over the facet there. And these are the multiple black stones, which are the pigment stones. So what about the pigment stones? It is very important thing is the pigment stones most common and almost always found in the gallbladder. Black pigment stones. It is commonly found in the hemolytic disorder and also often seen in the cirrhosis of the liver. That too causes more breakdown of the RBC and causes more hemolysis, and that causing the pigment stones forms, and which are the black pigment stones. And multiple small and hard in consistency, easily black pigment stones. And what about the brown pigment stones? Rarely found in the gallbladder, formed in the bile duct as a primary biliary stones. It is a very, very important thing it is. There is called the primary biliary stones. That means the stones which forms in the biliary common bile duct without the gallbladder, then it is called the primary bile duct stone. Formed in the bile duct as a primary biliary stones. Commonly occurs due to the bile stasis and infected bile. The infected bile may occur due to the E. coli, Escherichia coli, bacteroids cause the formation of the bacterial nidus, and at the center the formation of the stones. So these are about the brown stones and the pigment stones, black pigment stones. What about the risk factors of the gallstones? So the risk factors are age. The prevalence of the gallstone increases with age. And sex preference is more in case of female, common in female at all ages, and may be an effect of female sex hormones. For that reasons, there is a formation of the stones more in case of female. Oral contraceptive therapy, those individuals who are taken, there is a more associated with the formation of the cholesterol stones. So it is associated with increased cholesterol saturation, and these drugs increase the incidence of cholesterol. So those ladies who are taking the oral contraceptive pills, there is a more chance of development of the stones. Then other is the obesity. That means increased obesity, that means increased cholesterol, increased fatty tissue within the body. So there is more prone to develop, increases supersaturated bile. Thus increases the risk of stone formation. And another important thing it is the diabetes mellitus may be associated with increase in the prevalence of gallstone related to the cholesterol metabolism and gallbladder dysfunction. So diabetes mellitus, in case of diabetes mellitus patient, there is more chance to develop gallstone. But all the diabetes does not having a gallstone. Maybe it is a predisposing factors, risk factors. Another important thing is gastric surgery, after gastric surgery. This is the important thing is, in partial fundoplication, that means in case of hiatus hernia, there is a nascent fundoplication or trupe, may be associated with an increase in the gallstone disease. It is important thing it is. In case of fundoplication, that means treatment of the hiatus hernia, the stomach gastric junction keep inside the abdomen. For that reasons, they make a wrap of the fundus of the gallbladder around the esophagus. So during that surgery, the vagus nerve are preserved. But that preservation of the vagus nerve during dissection, that time only injury, there is a chance to damage the hepatic branch of the vagus nerve. If the hepatic branch of the vagus nerve become damaged, so the gallbladder function become impaired. So there is a chance of gallstone formation after doing gastric surgery, like gastric fundoplication. And another important thing it is inflammatory bowel disease. That means Crohn's disease. due to the disease of the terminal ileum. Crohn's disease will affect the terminal ileum. So that causing inflammation, the full thickness of the wall of the terminal ileum. So whenever the inflammation of the gut wall, so there is the abnormalities of the absorption capacity of the mucous membrane. So in that time, there is a development of impairment of the bile salt, because that bile salt which are secreted and excreted through the bile duct to the biliary tree through the intestine, that passing down, and again the bile salt is absorbed in the terminal ileum mucosa, go to the liver by the enterohepatic circulation. So if the terminal part of the ileum become damaged by either surgical means or by the disease process, at that time there is a impairment of the bile salt concentrations in the bile, and there is a chance of stone formation, because the bile salt takes a part to dissolve the cholesterol within the gallbladder's bile. So if any concentration is different, at that time there is a chance of development of the gallstone more. For that reason, we are written, due to the disease of the terminal ileum leading to abnormalities in the enterohepatic circulation of the bile salt. Failure to absorb the bile salt and bile acids effectively alters the balance of the bile acids, leading to the smaller total bile acid pool. So for that reason, there is a chance of stone formation. In case of hemolytic anemia, that means hemolysis of the RBC, there are a lot of causes there: hereditary spherocytosis, electrocytosis, thalassemia. Most of all are hemolytic disease causing more breakdown of the RBC, more production of the pigment. For that reason, there is more formation of the stones. And total parenteral nutrition, it is an also important thing. That means whenever the patient cannot capable to eat or drink itself, long time postoperative period to some extent sometimes needed to keep the patient under total parenteral nutrition by IV access with the central venous catheter, give the all nutrition materials through this catheter. Nothing can put inside the mouth, go to the stomach in the intestine. So the whole GI tract, that means particularly stomach and the rest of the parts, become rest because the content of the food materials cannot pass through the mouth. So at that time, the gallbladder is not possible to functioning and there is a chance of stasis of the gallbladder bile within the gallbladder, and there is a formation of the nidus and stone formation. So for the exam in undergraduate level, not all the thing needed to know, but only you can only see, and sometimes may be written in the exam, or sometimes for the more mark in good students, that things sometimes asked in the exam. But that thing always remember by all the students. The gallstones having a 5F. The F is favorite for the surgeons. In the examination, what are the risk factors? The risk factors are the 5 Fs. That means F means fair, F means fat, F means female, and those having the age of 40, and those having a fertile. There's 3, 5F having more chance of development of the gallstone. But it does not the obligatory. Not all the time, all the 5s having correspondence with the gallstone disease. No. The stones may develop as low as age, that means at 4 years, 5 years. It may develop after 70 to 80, 90, 100 years of age. So no age are immune to develop gallstone disease. But usually that are the age groups, they are more prone to develop gallstones. So common groups people's, common age, common characteristics needed to know everybody's. For that is in the 5 Fs needed to everybody know for the exam. Next thing it is pathogenesis of gallstone formation. How the gallstones form? There is a 3 theories. One is metabolic, another was infect, another bile stasis. So the theories are, in case of metabolic one, you look, there is solubility of the cholesterol is determined. How far the cholesterol is soluble within the bile is determined by relative concentration of the cholesterol, bile salt, and lecithin. That three things having a proportionate relation to each other and causing to dissolve the cholesterol within the bile. So that relation must be known. Whenever the relation is altered, anything is more or anything is low, so the proportionate percentage of the composition altered, at that time there is a chance of precipitation and formation of the stones. So altered level of cholesterol, lecithin, and bile salts in bile reduces the micelle concentration. That three things forms together a micelle and which dissolve within the bile very smoothly. So that reduces the altered level of cholesterol, lecithin, and bile salts in bile reduces the micelle concentrations in the bile, leading to precipitation of insoluble cholesterol, hence the stone formation. Then when the relation, that means concentration of that three is altered, then it is called the lithogenic bile. That means supersaturated bile. So you must know the percentage of the compositions because it is very important thing. Though it is not written in the new edition of the books, these are written in the older edition books. Sometimes in the examiner asks in the exam, what is the relation of the bile salt and lecithin percentage and cholesterol? So the normal ratio of bile salt and lecithin to cholesterol is 25:1. 25% bile salt and lecithin and 1% is the cholesterol. The ratio is below 13:1, then there is a least to precipitation of the cholesterol. It is the important thing it is. When the ratio is altered from 25:1 to 13:1, then the precipitation of cholesterol develops. Factors increasing cholesterol secretions are old age. So old age, there is a more stasis of the bile and there is a more formation of stones, oral contraceptive pills, obesity, and those who are taking the anti-lipid drugs, clofiprid, they are having a more tendency to develop cholesterol. Factors reducing the bile salt concentration like estrogen, if you remove the terminalium, or there is a cholestyramine. So these are causing, there is a release, decreasing the bile salt concentration and formation of the stones. These are the metabolic theories. What about the infection? The role of infection in causing gallstone is unclear. Often bile from gallstone is sterile, but organisms has been cultured from the center of the gallstones. Bacteria like E. coli, Salmonella may be present, and parasites like Chloronochus sinensis and Ascaris lumbricus are often associated. Moynihan's aphorism, a gallstone is a tombstone erected to the memory of the organism within it. That means within the gallstone, there is a central nucleus of the organism. And among this infection, salmonella infections everybody knows because that salmonella causing stone formation, that salmonella causing having a chronic carrier of the patient and causing the chronic symptom there. So in that time, there is no stone, only the salmonella carrier. So the typhoid is not completely cured until and unless you remove the gallbladder. Because it is a chronic source of salmonella, is a chronic source of infection, which reservoir acts as a gallbladder. For that reason, sometimes the chronic typhoid disease, they needs to cholecystectomy for permanent cure of the disease from typhoid. What about the bile stasis? The stasis means stagnation there. There is no flow. So whenever there is no flow, there is a more chance of precipitation. So for that, the gallbladder contractility is reduced after by those who are taking the contraceptive pills in pregnancy and after truncal vagotomy, which predisposes to gallstone formation. If the patient having a gastric outlet obstruction due to chronic renal ulcer, so in that time we do the surgery. The name of the surgery is bilateral truncal vagotomy and gastrostomy. So we remove the vagus nerve So there is cut the supply also from the hepatic branch, also cut. So there is not functioning the vagus over the gallbladder. So there is less contraction of the gallbladder. More stress is there. There is subsequently after 5, 10, 15 years after doing the vagotomy bypass, the patient may present as a gallstone disease. Another important thing is bile stasis is the parenteral nutrition. Have a high incidence of gallstones. Lack of good oral intake prevents the release of cholecystokinin. So the hormonal function is whenever we take the fatty food through the mouth, go to the stomach, passes to the duodenum. Whenever the fatty food reaches in the duodenum, from the duodenal mucosa, there is release of cholecystokinin. That cholecystokinin passes through the blood, acts upon the gallbladder and causing contraction of the gallbladder, relaxation of the sphincter of the ampulla beta. So the bile can easily drain out from the gallbladder to the duodenum. So this is about the cholecystokinin mechanisms. So about these three things: metabolic, infective, and bile stasis. This is the pathogenesis of the gallstone. Sometimes in the written may present what is the pathogenesis of gallstone, that you write the three things only. Or sometimes in the exam, those who are taking the more mark for giving the more mark, some questions are asked in the exam. Or without knowing that mechanism, we don't able to understand the pathogenesis of the gallstone. So what about the presentations? Always we are presented, the symptoms are that two disease processes called the acute cholecystitis and chronic cholecystitis. But we remember about it, not only there's two. And another one is written the biliary colic. That thing we are always ignore, because that symptoms are not more marked. For that reason, we ignore that biliary colic. But this is the main presentation of the most of the individual, the biliary colic. Don't about the acute cholecystitis, chronic cholecystitis. No. The patient usually present to you is a severe pain, which is persists to sometimes, then relieved. This is called the biliary colic. That means sudden onset of constant severe pain in the right hypochondrium, lasting between 20 minutes and several hours, with pain often radiating to the back or right scapula. That means the pain whenever the pain occurs, it is right upper abdomen and radiate to the back and the right scapula. That is the radiation pattern. And this pain may be very intense and may be relieved by spontaneous, important thing it is impaction of the gallstones from the Hartmann's pouch and migration of the stones migration of the stones into the common bile duct. That means whenever the stone is impacted at the neck of the gallbladder, that means Hartmann's pouch, so the gallbladder, it is a narrowed area. For that impaction causing having a pain, and that pain is not relieved until and unless it go down towards the fundus or go down towards the common bile duct. So that two things can relieve the symptom, then the patient become almost normal. For that reason, it is called the biliary colic. And another thing is acute calculous cholecystitis. That means that infection is there, but that is associated with distension, infection, inflammation, gallbladder is distended, exudations, adhesion of the surrounding structures, and along with the systematic representations, systemic symptoms like fever, etc. Then it is called the acute cholecystitis. That means sudden onset of intense pain in the right hypochondrium. One thing. Then with time, as a sterile inflammation develops, the pain progresses to constant, severe pain lasting for hours or days. Pain may often radiate to the back and tip of the right shoulder. So that is the important thing it is. The pain radiates to the back and tip of the right shoulder. Tip of the right shoulder is caused because whenever the gallbladder is distended, inflamed, during respirations, the gallbladder fundus touches with the undersurface of the diaphragm. So that undersurface of the diaphragm causing the supply of the same segmental supply to the phrenic nerve to the shoulder. For that reason, the pain radiates to the right shoulder. The patient feels pain also on the right shoulder. So it is a very important landmark that the patient pain in the shoulder and pain in the abdomen on the right upper abdomen, which both of the things correlate to each other, and your diagnosis is almost confirmed that the patient having cholecystitis, acute cholecystitis. And along with that, the patient having fever. So fever due to the infection and inflammation, the systemic presentation of fever, and nausea and vomiting, important thing it is. Whenever any source of pain in the abdomen, the body defense attitude, there is a pyloric spasm, no further intake in the abdomen. So it helps to decrease the abdominal content, decrease the abdominal distension, and body defense attitude. There is a representation is there is a nausea. So if you're having nausea and vomiting, you don't take any food. So it is a body defense attitude, nausea and vomiting. That two presentation also at the time of acute calculus cholecystitis. This is about the acute calculus cholecystitis. But sometimes the patient does not having a stone there, but the presentation of cholecystitis are the same. There is a distension, so there is gallbladder is edematous, touches the diaphragm, touches the parietal peritoneum, so there is a pain, all the same. And in case of chronic calculus cholecystitis, that means there is having a cholecystitis which resolves by conservative treatment, oral antibiotics or systematic antibiotics, nothing in mouth, etc., and relieved. But the wall of the normal gallbladder is a thin wall, but in case of chronic cholecystitis, there is whenever there is inflammation, there is a deposition of collagen tissue. For that reason, the wall becomes thickened subsequently. So when the gallbladder is thickened wall, it is not capable to distended mode, don't able to function properly. For that reason, the patient having dilating pain in the right upper abdomen, upper quadrant. Dilating pain. It is not more marked pain there. Dilating pain, right upper quadrant. And pain may refer to the tip of the right shoulder or to the back sometimes. Pain aggravated by taking fatty food. It is important thing it is. If the pain is aggravated with the fatty food intake, most likely the patient may having a gallstone. Then you examine the patient by investigations and prove that there is stones or not. And another thing is flatulent dyspepsia. That means feeling fullness after food associated with belching and heartburn. It is brought on by a large or a fatty meal. And in that case of chronic cholecystitis, the patient does not having a fever. The patient does not having any more marked of nausea and vomiting, etc. So it is less symptoms. For that reason, the diagnosis is very difficult. Until and unless clinical diagnosis is very difficult, until and unless you do some investigation like ultrasonography, then you can diagnose that the patient having gallstone disease. Another important thing is the clinical presentation is symptoms. The gallstones may be asymptomatic, which is termed as a silent gallstones. The patient does not having any sorts of symptoms. Suppose the patient having a twisted ovarian cyst or the ovarian tumor or the fibroid uterus or etc. is the gynecological symptom, or the patient having urinary diseases, then do an ultrasonography of the whole abdomen to evaluate the disease. Then incidentally diagnose the patient having gallstone. But the patient does not having any sorts of upper abdominal pain or the fatty food intolerance, etc. For that reason, the stone may be asymptomatic. So some are asymptomatic and most of the patients are symptomatic. The symptomatic one having a three presentation: biliary colic, acute calculus cholecystitis, chronic calculus cholecystitis. These are the presentations of gallstone disease. Then the comparison of the clinical study of sign of acute calculus cholecystitis and chronic calculus cholecystitis. So look, in case of acute calculus cholecystitis, the temperature is raised and there is a temperature normal. But whenever there is a temperature raised, along with there is a raised temperature causing increased tachycardia. That tachycardia also due to the pain of the abdomen. So pain causing increased pulse rate, increased fever causing pulse rate. So both of them causing the presentations along with temperature. There is an increased pulse, that means tachycardia. But there is not marked tachycardia is there because there is no pain mark, no temperature raised. But on local examinations, this is the most diagnostic clinical sign that the patient may have a cholecystitis. That means tenderness in the right hypochondrium. That means the gallbladder lies in the right hypochondrium. So whenever the parietal peritoneum touches the inflamed gallbladder, so the body defense attitude, there is inflammation of the gallbladder parietal peritoneum, causing reflex spasm of the muscles to decrease movement, localize the infection for that reasons. So that decrease movement of the muscles, contraction of the muscles, it becomes rigid. Whenever you examine, the right upper quadrant muscle become more rigid in comparison to the left side. So this is called the muscle guard present on the right side, right upper abdomen, muscle rigidity also present. And if you examine the Murphy's sign, that means you make a constant pressure over the tip of the index finger and ask the patient to take deep breath. So the deep breath causing the movement of the contraction of the diaphragm, movement of the gallbladder and the liver from the up to the down, that down causing directly heated over the gallbladder fundus. And whenever that touches the parietal wall with the gallbladder, the patient feels more pain. This is called the Murphy's sign. Then you press the gallbladder area, that means tip of the ninth coastal cartilage, with your thumb, make a constant pressure there, ask the patient to take deep breath. At the maximum highest point of the breath, the patient feel pain more. This is the diagnostic signs of Murphy's sign for cholecystitis. And another one is the Bose sign. It may be present that the Bose sign is not in front, it is behind 9, 10, 11 rib at the level on the right side. On the right side, if that area become more, alter the sensation, hyperesthesia. So it can also diagnose that the patient may have been cholecystitis. And sometimes the gallbladder may be palpable. If the patient is lean and thin, at that time you may palpate the gallbladder. Or if the gallbladder is more distended, big size gallbladder, in that case you may be palpate the gallbladder during palpation. So this is about the acute calculus cholecystitis. But in case of chronic one, there is no tenderness in the right hypochondrium, muscle guard absent, muscle rigidity absent, Murphy's sign negative. Gallbladder may be palpable if there is associated with mucosal or empyema gallbladder, otherwise not. So these are about the acute cholecystitis and chronic cholecystitis signs. So there is a sense triad. Some diseases may along with the gallstone. So there is a discovered that there is a triad which is called the sense triad. That means gallstone disease along with maybe diverticulosis of the colon and hiatus hernia. So the hiatus hernia having epigastric pain, the gallstone may be silent one. So every gallstone does not produce any symptom. For that reason, if the patient having a gallstones, you may evaluate very carefully the symptom. The patient may having any reflux or not. The patient may having any source of hiatus hernia or not. That hiatus mislead you as a symptom of gallstone disease, but the disease is due to the hiatus hernia. If you do the gallstone, the symptom is not improved because the presentation is due to the hiatus hernia. For that reason, in case of sense triad, there is a gallstones, maybe associated with diverticulosis of the colon and hiatus hernia. What about the Murphy's sign or Nernst signs? That means the Nernst sign named after Bernhard Nernst, professor of medicine, Strasbourg, who described it 13 years before John Benjamin Murphy. 13 years before he discovered, is elicited by asking the patient to breathe in while gently palpating the gallbladder area, tip of the ninth coastal cartilage. The patient will experience pain and catch her breath. When the patient feels more pain, in that time the patient held up breath. So it is called the catch her breath just before the height of inspiration. Because when there is a height of inspiration, at the peak of the height of inspiration, more contraction of the diaphragm, the liver is go down more contact with the gallbladder with the finger. So there is more pain. For the pain, the patient catch her breath. So it is the positive in acute cholecystitis, which is called the Murphy's sign. So these are about the Bose sign. Area of hyperesthesia between 9th and 11th ribs, posterior on the right side. So this picture is shown there on the back side, touches with the finger, touches with the hand. It is usually not touch with the hand. It is better to touch with the cotton bud. That is cotton, small amount of cotton taken in the hand and just rub over the surface. And if the patient feels some discomfort more, that indicates that the patient having a hyperesthesia. What about the investigations? So diagnosis needs to confirmation. Clinically you can diagnose, but it is not the confirmation. Confirmation is done with the support of investigations. So the supportive investigations depends upon what type of disease you think. Then you send the patient to some extent of investigation according to your assumption what type of disease it is. For that reasons, in case of acute calculous cholecystitis, that means acute infection. So acute infection having a systemic manifestation is leukocytosis. That means neutrophilic leukocytosis. So for that reason, you give a complete blood count, CBC, complete blood count, which indicates there is a neutrophilic leukocytosis. That indicates it is a supportive investigation there. Definitely the patient having a acute cholecystitis there. One thing. Second thing is, but in case of chronic cholecystitis, that total count is normal because the patient does not having source of more infection there. So there is no systemic manifestation. So there is no more total count. There is a normal total count maybe there. Not marked like this acute cholecystitis. There is a marked increase. 18,000, 20,000, 25,000 maybe total count. But here it is normal 4 to 6 or 7,000. So what about the liver function test? It is important thing it is. Because the diseases of the gallbladder, the structure is related with the liver. For that reason, so very close to each other, and for that reason the liver function must be needed to evaluate. Some complication of the gallstone may alter the liver functions, or the patient may having some presentation due to the liver disease, not the cholecystitis. In the patient of hepatitis, there is a capsule is enlarged, the gallbladder liver is distended, capsule is more stressed, the patient may feel pain. So liver function also evaluated, but is there any alteration or not? The confirmatory investigation is ultrasonography. It is very important thing it is. That means ultrasonography of whole abdomen with the special attention to hepatobiliary system and pancreas. So whenever you do the ultrasonography, then you can easily detect that the patient having what is the status of the gallbladder is. What is the gallbladder lumen? What is the wall of the gallbladder? What is about the surroundings of the gallbladder? All information you can guess by looking the ultrasonography. For that is an ultrasonography you must do. Then you do a simple investigation which is called a plain X-ray abdomen. That plain X-ray abdomen is not needed all the time to do. If any confusion that other disease may be associated with, at that time we can do a plain X-ray abdomen. But that plain X-ray can give information not all the time, to some extent of the time can dictate some disease of the hepatobiliary system or the gallstone disease are. The gallstones are not the radiopaque. This is the only 10% stones are radiopaque. The less amount of calcium there. So for that is it not visualized in the plain X-ray. But in case of renal stones, the 90% are radiopaque. For that reason, for renal stone diagnosis, the plain X-ray is most of the time is required. But in case of gallstone, not all the time required to do a plain X-ray. But if you do a plain X-ray, sometimes you may diagnose a gallstone there by looking at plain X-ray. This is called the gallstones, and sometimes there is the porcelain gallbladder. That means the gallbladder wall become calcified and rounded. So porcelain gallbladder means you look at X-ray, there is this calcium deposition over the whole of the gallbladder lumen wall. So the deposition can be presented as a spotted calcium deposition of a pear-shaped organ at the right hypomembranous. That represents that the patient most having a porcelain gallbladder. And sometimes some infection causing gas produced within the gallbladder. So if the gas produced within the gallbladder, the gas lies within the gallbladder. So if you do an X-ray, there is an outline of the rounded structure, pear-shaped structure there, and within the pear-shaped structure, there is a gas shadow. So this is called the emphysematous cholecystitis. And sometimes may mimic with peptic ulcer perforation, the duodenal ulcer perforation, pain in the right upper abdomen. To exclude that, you can do a plain X-ray abdomen in erect posture or plain X-ray chest in erect posture. You can easily diagnose the patient does not having any sorts of perforation there. For that reason, this is done for a plain X-ray abdomen. But that whenever you see a plain X-ray, there is a gallstones. At that time, you have some confusion that the patient, that radiopaque shadow may be renal stones. So for that evaluation, for needs and another X-ray, which is called the X-ray abdomen in a lateral view. If you do an X-ray lateral view, then you can easily demarcate by looking the previous X-ray that radiopaque shadows lies in front of the vertebral body. That means when the calcified shadow lies in front of the vertebral body, in upper abdomen, most likely it is gallstones. But whenever the stones is superimposed or behind the body, then your diagnosis is renal stone. Because whenever we are lying in the bed, the kidney lies on the gutter. So it is far away behind the vertebral body level. For that reason, do an X-ray in the lateral view. The stone is superimposed on the renal stones over the vertebral body. This question is also asked in the exam. How can you differentiate a renal stone from a gallstone by a plain X-ray? Your answer is do a lateral X-ray abdomen. Then I can differentiate why it is in front or behind. If it is in front of the vertebral body, then it is the gallstone. If it is behind the vertebral body or at the level of the vertebral body, then it is the renal stones. The other investigation nowadays that are not done, these are the previous teaching, that means HIDA scan. It is one of the isotope scan. That HIDA agent, that means hepatobiliary immunodiacetic acid, that isotope is introduced and administered. After that, they do with the gamma camera, they do an image scan and give a picture that the isotope excreted through the liver to the biliary tree, and some isotope passes to the gallbladder, stay there. If the gallbladder lumen is patent, the HIDA materials can accommodate it. Isotope is accumulated in the gallbladder. By a scan, they detect that there is a gallbladder visualized. That means whenever the gallbladder lumen is patent, there is no acute inflammations. It is the diagnostic proved. For that reason, if doing a HIDA scan, if the gallbladder is not visualized, then your diagnosis it is acute cholecystitis. If the gallbladder is visualized, then the diagnosis is it is not acute cholecystitis. So for that reason, here written, the HIDA agent is excreted in the biliary tree within 1 hour of isotope administrations. In acute cholecystitis, even isotope is excreted in the biliary tree, it does not enter the gallbladder due to the edema of the cystic duct. So there is no visualization of the gallbladder. Then the diagnosis is confirmed as by doing an HIDA scan, it is acute cholecystitis. But nowadays it is not done because it is not possible, it is not available in all the centers. Only the nuclear medicine center it can possible to do it. For that reason, it is not a common investigation. These are the previous investigations. The another common investigation tool is the CT scan. It is a very important tool because nowadays it is more available in our country also. Previously it is less in number, but it is available in most of the big cities. For that reason, we are in future more oriented to the CT scan. So not only detects the gallstone, by doing a CT scan, you can evaluate not only doing the gallstones, but also detects if any perforation or any collection, you can directly see within the picture. Used when ultrasonography findings are not clear. Ultrasonography does not give any clear information sometimes. Very confusing information there. In case of aciculous cholecystitis or in case of perforated gallbladder. So that two things can be easily, or is there any malignancy, you can easily evaluate by looking at the CT scan. For that reason, CT scan also take part role nowadays also. So what about the chronic cholecystitis? That chronic cholecystitis diagnosis is the only one is the ultrasonography. So that ultrasonography can detect that the patient having a stone there, the wall become thickened. So that two things can detect that the patient having chronic cholecystitis. And others are porcelain gallbladder can also give information by ultrasonography, and it also can do an X-ray. You can evaluate the patient porcelain gallbladder or not. And important thing, it is porcelain gallbladder. It is a precancerous condition. Though it is not a stone in the gallbladder, but must be needed to remove the gallbladder, because in future, at any time, patient may turn into the malignancy, carcinoma gallbladder. For that reason, one of the indications of porcelain gallbladder is cholecystectomy. Other like CT scan not only detect the stone but also detect the wall thickness. You can easily look the CT scan, the wall thickness it can also detect the patient having a gallstone along with chronic cholecystitis. So look at the pictures. Ultrasonic picture of normal gallbladder. So very precisely delineated the whole gallbladder outline. This is the gallbladder wall. Whole gallbladder wall there. In the lumen, it is clear. Nothing is there. So the information is, there is a normal hepatobiliary system. So these are the biliary tree within the liver. The biliary trees are visualized. These are the magnifying picture. For that reason, this is impression is a dilated one. But it is the normal. There is a smaller picture, more smaller in size in visual. For better delineation, the magnified picture can be presented there. So, what about the ultrasound findings? Because whenever you pass the MBBS examination, you must need to know what are the findings written in the ultrasonography report by the sonologist. Because everybody, we are more oriented towards the comment about cholelithiasis. But that cholelithiasis can read and know not only the doctors but also the patient and also the quacks. They know about the cholelithiasis. But what are the findings that the patient having the report is cholelithiasis? You are the student, you are the MBBS doctor, you must know. Otherwise, you don't evaluate the disease process properly. Look, this is the gallbladder. The ultrasonic language is, whenever anything within the lumen of the gallbladder other than normal bile, that thing becomes more hazy in appearance of within the lumen. Look, there is a hazy structure there. So that hazy appearance is called the echogenic structures. Echogenic, this is the ultrasonal language, because the ultra high frequency sound is placed over the surface of the abdomen, which the sound is passes inside the abdomen, and whenever the stone is there, whenever the stone within the gallbladder lumen, the sound is passes from the up to the down to the liver within the gallbladder, then the echo structure, the sound wave is go back, because it is a tough structure, hard structure for that. So whenever the sound is go back, there is a shadow. Look, there is a shadow. there is a shadow behind the echogenic structure. So that echogenic structure with acoustic shadow that represent that the patient having stone within the gallbladder. It may be single, it may be multiple. But look at the picture. There is a echogenic 1, 2, 3, 4, 5. And more also on behind me. So the representation is multiple echogenic structure within the lumen with acoustic shadow, with acoustic shadows that represent that the patient having gallstone disease. So look, single or multiple bright echogenic structures casting posterior acoustic shadow are impacted in the neck region of the gallbladder. Not only the neck, body and neck also. So this is the descriptions, because sometimes the sonography report, they only cut and paste the previous report. So the patient having does not any source of stones there. So normal study of the gallbladder. But in the comment, he mistakenly does not cut the cholelithiasis. So normal study don't written there, only the cholelithiasis. So by looking at the cholelithiasis note, if you do the surgery, subsequently there is no stone there. So if you evaluate the comment, evaluate the picture, then you confirm that the patient having definitely there is stones. For that reason, everybody before surgery, you must know, you must examine the sonology report and picture. And another thing is, look at the gallbladder size of the gallbladder. Then wall of the gallbladder. So look, the wall is more thickened. Then another one is pericholecystic collection. Look, there is a wall, that wall is echogenic, and behind that there is a black area. So that black area is represented, there is a edema. Edema exudate fluid accommodated between the liver bed and the gallbladder. So it is called the pericholecystic collection. So the impression is, the diagnosis is, sonography diagnosis confirmed that the patient having is acute calculus cholecystitis. Acute calculus cholecystitis. It means acute infection, for there is a pericholecystic collection, wall is edematous, wall is thickened, and there is a multiple stones there. For that reason, this is called acute calculus cholecystitis. Look the second picture. So compare the previous one. So compare the previous one. You look, you can easily see in the lumen of the gallbladder. Look, so there is a bile there. And look at the picture. There, the lumen is contracted. There is a echogenic structure, there is a shadow. The lumen is not clean cut demarcated there. That means there is a repeated tract of infection. So the wall is thickened, contraction of the gallbladder, the lumen is contracted. So the bile is not moved inside the lumen. So this is about the chronic, the echogenic structure with the shadow. Look, there is no shadow, but there is a shadow. So that echogenic structure casting acoustic posterior shadow, and the gallbladder is contracted, and also to some extent thick wall. So the diagnosis is chronic calculus cholecystitis. But there is no pericholecystic collection there. Another important thing is, look at the picture, there is echogenic structure. Always remember it is echogenic structure there. So that echogenic structure having some shadows there. But if you look in the other picture, sometimes there is echogenic structure clean cut within the lumen seen, but there is no shadows. But there is no shadow. If there is no shadow, only there is echogenic structure, there is no shadow, then you think that it is not a stone probably. But what thing it is? It could be a gallbladder polyp. It could be a gallbladder polyp, because if there is a gallbladder polyp, there is a protrusion within the lumen. So that protrusion also gives the images like a echogenic structure. But there is no hard structure for that, is don't give any source of shadow, because the sound is passes through the polyp downwards. There is no back image. For that reason, there is no shadow there. So whenever there is a stone, there is echogenic structure within the gallbladder, the echogenic structure within the gallbladder, then two things you think. One is gallbladder stone, another thing is gallbladder polyp. But in case of gallbladder polyp, there is no shadow in the ultrasonography, no echogenic structure, but without acoustic shadow. Without acoustic shadow is your diagnosis gallbladder polyp. Then your confusion you can more confirm by changing the position of the patient. If you change the position of the patient, that means if the patient is supine, if you tilt laterally or the right or left, then the gallbladder polyp, if it is in this surface, it is always constant in position. But if there is a stone, it will migrate there or there. It is not in a constant single position. If it is a constant in position, there is a echogenic structures, no shadows behind it, your diagnosis is gallbladder polyp. Be careful about it. Echogenic structure with posterior acoustic shadow, then it is diagnosis gallstone. Echogenic structure without acoustic shadow, then your diagnosis is, and no, don't change with the posture, then your ultrasonography diagnosis is gallbladder polyp. Another important thing is sometimes the bile become more thickened, which is called the gallbladder sludge. That sludge sometimes gives the information about the echogenic structures. It also gives echogenic structures without shadow. But you are confusing about the echogenic structures. So echogenic structures usually is the polyp. So what thing it is? It could be a gallbladder sludge. So how can you differentiate? Same thing, you just change the posture. If you change the posture, the echogenic structure is changed from one to another area because there is sludge which floats within the gallbladder. But in case of polyp, it is attached to the muscles. So there is in a fixed point. But in case of posture change, no acoustic shadow, without shadow, change your posture, your diagnosis, it is gallbladder sludge. So fixed in location, without acoustic shadow, echogenic structure, polyp. Posture change the position, acoustic shadow, without shadow, it is gallbladder sludge. And change the posture, echogenic structure, along with shadows, it is called stones. So these are the sonographic differentiating point. But all the things are not required your undergraduate level. Only I can describe to clear your conception. Because if you clear your conception, you can in future easily look the picture, look the image, and you can easily diagnose. Don't depend upon the report. You can directly confirm and challenge by looking the ultrasound picture. So this is the chronicle studies, single multiple bright echogenic structure casting posterior shadows and present in the lumen of the shadows are present in the lumen of the gallbladder, and gallbladder is contracted, wall is thickened, pericholecystic collection is absent. So your diagnosis is chronic calculous cholecystitis. So look about the plain X-ray abdomen. Lot of pictures there. So the gallstones are radiopaque 10%. So look at the picture. Look at the pictures, radiopaque gallstones. There are 1, 2, 3, 4 stones sitting within the gallbladder. And this is, look, there is a multiple granular lining white appearance represent as pear-shaped gallstones. So it is just like an eggshell, which is called the porcelain gallbladder. And look at the picture. There is a gas shadows, rounded gas shadows in the gallbladder fossa. So most likely it's emphysematous cholecystitis. And do an X-ray chest in erect posture or plain X-ray abdomen, including both domes. There is a crescentic gas shadows. That crescenting on the right side, there is a gas shadows. This represents the perforation. So that crescentic gas shadow may be on the right side, maybe on the left side. On the left side, there is a confusion because the funding gas usually present on the left side. So for then on the right side, easily can diagnose. On the left side, very consciously look the picture, is there any gas shadow on the left side or not? Both the side or the single side may be presented as a free gas shadow under the diaphragm, represented as a perforation. That means pneumoperitoneum. Lot of causes of pneumoperitoneum there. May not be peptic ulcer, other causes may be. That means pneumoperitoneum can be diagnosed with a plain X-ray abdomen erect posture or X-ray chest, plain X-ray chest in erect posture. So also to exclude the peptic ulcer, emphysema. These are the pictures representations. There is a radio opaque gallstones in 10%. Tri-radiate fashion if the calcified shadow there, which is called the Mercedes-Benz sign, and biradiate sign is seagull sign. These are the gallstone signs. Radio image sign. So look about the differential diagnosis of a radiopaque stone shadow in the right renal regions. So right side renal stone 90% radiopaque, calcified mesenteric lymph nodes. It is another thing. Be careful about it. The mesentery having a lot of lymph nodes in the abdomen, which are located here and there. So in case of tubercular lymphadenitis on the abdomen, healed by anti-tubercular drug, and subsequently it becomes healed and some calcifications. So that calcified lymph node, which may be represented with the gallstones of the renal stones, it may be a calcified mesenteric differential diagnosis, gallstone in 10% cases, and concretion in the appendix. If the appendix is high up, sometimes the fecalith may be radiopaque. And some tablets or foreign birds in the alimentary canal, maybe look at the shadows on the plain X-ray. So it may be misdiagnosed as a gallstones. So flavolite, calcification in the wall of the veins, especially in the pelvis, and ossified tip of the 12th rib. Tip of the 12th rib may be ossified, represented as a calcified shadow. And calcified tuberculosis in the kidney. Tuberculosis of the kidney also takes some calcification shadow and calcified adrenal glands. So all of them are differential diagnosis by looking at radiopaque shadow on the right renal regions. And how can I differentiate gallstone or renal stone in plain X-ray? That is the very important. Gallstone is anterior to the arterial column on plain X-ray, lateral view, while renal stone is posterior to the arterial column. So these are the differentiating point of X-rays. So look at the HIDA picture, HIDA scan. So look, the HIDA scan, isotope and go into the biliary common bladder is visualized, the gallbladder is visualized. So there is a normal HIDA scan. So here the gallbladder is not visualized. Only the biliary, the intrahepatic and extrabiliary is visualized. The gallbladder is not visualized. For that reason, there is a known filling of the gallbladder, tracer in the CVD, tracer in the small gut. So this is the acute calculus cholecystitis. Nowadays it is not done. So what about the complications? Every additional thing in the body causing some complication. So this stone is formed inside the gallbladder. So whenever it inside the gallbladder, it may be asymptomatic. There is no infection, no presentation is there. But sometimes the stone passes or impacted the neck and detached within the lumen of the gallbladder or go into the biliary downwards. Then it is called the biliary colic. And then stone is causing obstruction, infection, inflammation, which is called the acute cholecystitis. Whenever disease is subsided by conservative manner, and subsequently there is to some extent of pain, dialectic pain in the right upper abdomen, which represented as chronic cholecystitis. And the neck of the gallbladder, when it is impacted, the gallbladder lumen is filled up with the bile. The bile it become infected, which turns into the pus in the gallbladder, which is called the empyema of the gallbladder. Sometimes the acute cholecystitis is not resolved, treated by surgically or treated conservatively. That if it is untreated, at that time the gallbladder is more distended, there is a necrosis, there is a perforation of the gallbladder. So perforation may happen, or the stone is impacted there. So the infection causing the mucous membrane, the infection causing does not the bile enters inside the gallbladder from the common hepatic duct. So the neck is obstructed. So neck obstruction causing the bile remains inside the lumen, which become absorbed by the mucous membrane, and the mucous membrane having a tendency to secrete mucus within the lumen. So gradually the bile is replaced by the mucus. So the mucus is a clear fluid. So gradual distension causing gradual adaptation of the muscle wall, the gallbladder become more thin and transparent, which is called the mucosal of the gallbladder. And sometimes the stone present inside the gallbladder causing irritation. So chronic irritation causing some changing in the malignancy. Sometimes without stone, the patient may have been presented with the malignancy also. So chronic irritation and malignancy formation, it is called the squamous carcinoma. But usually the common malignancy is the adenocarcinoma of the gallbladder. So this is the gallbladder effect. So effects are acute cholecystitis, chronic cholecystitis, empyema of the gallbladder, perforation of the gallbladder, mucosal of the gallbladder, and carcinoma of the gallbladder. So if you understand the effects, so you can easily memorize. Otherwise, if you don't understand, you can miss some effects of the gallbladder. So these are the effects over the gallbladder. Then the stone passes through the duct to the common bile duct. So the common bile duct is a narrow lumen. So whenever the stone is there is obstruction of the biliary excretions. So that obstruction causing there is a jaundice formation. So it causing obstructive jaundice. So there is a secondary CBD stones. That means the stone is migrated from the gallbladder to the common bile duct. It is called the secondary CBD stone. Whenever the stone is formed within the common bile duct, it is called the primary common bile duct stone. The stone is due to the other causes from the gallbladder migrated. It is not formed there. Then it is called the secondary CBD stones. So effect is a secondary CBD stone, which causes stasis, and that stasis causes there is infection. So there is a cholangitis. Another one is the Meiji syndrome. That means the stone is not dislodged there. Stone is impacted there, and it causing pressure bit over the common hepatic duct. So which is called the Meiji syndrome. Later on I discuss more elaborately with the Meiji syndrome. So what about the pancreas? So the patient may present with the acute pancreatitis. The presented as acute pancreatitis because the stone is passes to the CBD, passes through the ampulla to the gallbladder. So the ampulla better become distorted, so which causing reflux of bile content, duodenal content in the pancreatic duct, and the patient may develop the acute pancreatitis. And other important thing it is, sometimes the disease of the gallbladder may presented as an intestinal disease. That means the stone whenever passes from the gallbladder to the intestine, and the intestine there is obstruction, and the patient presented with intestinal obstruction, which is called the gallstone ileus. That means the gallbladder stone is migrated from the gallbladder to the duodenum by a fistula, which is called the cholecystodiodinal fistula, causing gallstone migration to the intestine and obstruction, which is represented as a gallstone ileus. These are the effects of complication of gallstone in the gallbladder, in the CBD, in the pancreas, in the intestine. Sometimes it is in the OSPE, sometimes a written question may present, sometimes ask in the exam. Tell me the effect of gallstone in the gallbladder. Tell me the effect of gallstone in the CBD. Tell me the effect of gallstone in the pancreas. Tell me the effect of gallstone in the intestine. So that chart everybody must know, everybody must memorize it for passing the exam. For the military, look, so military and ask in the so pain reduce the back. So then gallstone may affect the gallbladder or it go down. So what about the treatment? So treatment, it depends upon the diagnosis. What about the diagnosis? If it is acute calculus cholecystitis, so the patient having acute symptom there, more severe pain, temperature, so there is infection inside the body. For that reason, the treatment plan is first conservative approach is started, nothing per oral, put in nasogastric tubes, rest the stomach to suck it out, and IV infusion of fluids to replace the fluids, and broad spectrum antibiotics to kill the bacteria infection, give the analgesia to take normal sleeps, deep breath, no pulmonary complications subsequently, and observe the patient. When the temperature, pulse, and other physical signs show that the inflammation is subsiding, usually by the third day, the nasogastric tube is removed, fluids, and followed by a fat-free diet are given. But at that time, if their symptom is free, the patient can able to eat food, then you can discharge the patient and advise the patient after 6 weeks go for the cholecystectomy. That cholecystectomy by open or laparoscopy method is performed during the same admission 2 to 3 days after the acute episode is resolved, or the patient is fit enough, you can do immediately within 1 day maybe. If there is other investigations or parameters are normal, that means fit for the patient, then you can do it surgery immediately, or conservatively treat the patient, discharge the patient must be abandoned if the pain and tenderness spreads across the abdomen and the pulse rate rises percutaneous. It is another option. That means when the condition is deteriorating, you think that you don't able to do the cholecystectomy. The cholecystectomy is very difficult for the patient and for the surgeons. Then you can relieve the symptom and emergency overcome by drain the gallbladder with a tube, which is called the cholecystostomy. That means conservative treatment must be abandoned if the pain and tenderness spreads across the abdomen and the pulse rate rises. A percutaneous cholecystostomy is performed by a radiologist under ultrasonic guidance control with rapid relief the symptoms, and subsequently cholecystectomy will be required. These if the facilities are available there, in that cases may be done. In case of acute calculus cholecystitis, why emergency cholecystectomy is not done usually in acute cholecystitis? Because extensive adhesions makes difficult dissections, difficulties in identification of structures, excessive bleedings, inadvertent injury to the bile duct, hepatic artery, and portal vein. But it can be performed if the surgeon is experienced enough and the operation tool machineries are good, image system are available. You can do it because within 48 to 72 hours, there is adhesion of the gallbladder with the bed and the structures are filmy adhesion. If you hold it, suck it out, release the content, easily can dissect it because there is a pericholecystic edema. But previously, the old theory conceptions are do the surgery later on, no treatment of acute cholecystitis until and unless the patient does not resolve the acute cholecystitis. But nowadays, the treatment options is if you are expert enough, if your facility is available, more rich facilities there, you can, the patient is fit, then you can go for laparoscopic cholecystectomy in the same sittings. But in case of chronic calculus cholecystitis, the cholecystectomy is the treatment options. That there are two options. One is open cholecystectomy and another is laparoscopy one. But nowadays, the laparoscopic cholecystectomy is the gold standard treatment of cholecystitis. There is no confusion that the treatment, first line treatment option of gallstone disease or cholecystitis is laparoscopic cholecystectomy. But in the exam, whenever you ask the questions, if the patient having acute cholecystitis, calculus cholecystitis, what treatment you advise? Your treatment option is first do the conservative treatment, then resolve it and advise discharge the patient after 6 weeks, advice for cholecystectomy. This is the normal common answer for your level. But if further query done, if you don't go for acute cholecystitis, you don't go for acute cholecystectomy, then your answer is If the surgeon is expert enough, patient is fit for surgery, then their treatment option may be done with acute stage. In acute stage, go for cholecystectomy, same sitting. What about the cholecystectomy, open cholecystectomy? Previously, we are more accustomed or orientation with the cholecystectomy by an open surgery one. Nowadays, it is converted into laparoscopy one. But open cholecystectomy, all the surgeon must be know, because during cholecystectomy, is there any accident happen? In that case, is needed to do open surgery. For that reason, open cholecystectomy must be known in every surgeon. Otherwise, never ever try for laparoscopic cholecystectomy, because without knowing the open knowledge, you don't able to do the laparoscopy surgery. So the anesthesia, sometimes asked in the exam, what anesthesia given for cholecystectomy? The answer is general anesthesia. The answer is general anesthesia. That means under general anesthesia with endotracheal intubation. So intubate the lungs, so the respirations are maintained with the machines, and through the tube give the anesthetic agents like halothane or isoflurane or sevoflurane along with oxygen and nitrous oxide. That three gas is introduced through the endotracheal tube: oxygen, nitrous oxide, and halothane. Nowadays, the halothane are hepatotoxic. They are changed over to isoflurane or sevoflurane. They are more safer drugs. Sevoflurane are the more safer for the children. And isoflurane is more safer for the adult. But our country, we are more oriented with the halothane because it is cheaper one. For that reasons, halothane, isoflurane, and sevoflurane are more costly. So after giving the anesthesia, your first thing is painting the operation field with antiseptic solution. Then you're draping the operation field with a draping sheet. That means the operation site is only exposed. The other area become covered with the draping sheet. Then your plan to make an incision. So incision, there is usual, the incision given is called the Coker's incision. That means right subcostal incision. So right subcostal incision, the name of is Coker's incisions. The left subcostal incision is not the Coker's one. It is subcostal incision, but the right one specific name is Coker's incision. Sometimes in the exam asks the spelling of Coker's, K-O-C-H-E-R. Be careful about it. Sometimes this question is asked in the viva or in the written, the name of the operation, incision name of the right subcostal incision. It is Coker's incision, K-O-C-H-E-R apostrophe S, Coker's incision. So what type of incision it is? So the name is represented right subcostal. That means in the subcostal regions, the incision is made. So how it is made? The incision is made from the midline towards laterally on the right side. So the incision is parallel to the costal margin. Parallel to the costal margin, go laterally from the midline. So for that, it is an oblique incision that is started in the midline below the Gifford process and extend downwards, outwards, and parallel to about 2.5 centimeters below the right costal margin. Below the right costal margin, the incision started from the Gifford process, go down parallel to it, usually up to the anterior line. Sometimes if it is difficult, then you can go up to the mid-axillary line. It depends upon the demand of exposure of the operation field. So this is about the incision. So after giving the incision, then your plan is to remove the gallbladder. So for removing the gallbladder, your first thing is to visualize the gallbladder area. So gallbladder is visualized by retracting the contents of the abdominal contents. That means you retract the parietal wall. You needs to retract the parietal wall in the upper part. You retract the parietal wall in the down part. You retract the viscera, which is relation with the downward to the gallbladder. So if you retract it by the retractor, then the field is visualized, the gallbladder is visualized there. So for that reason, after that, you retract by retractor, upper part is retractor, the Devers retractor, Morris retractor, and then you place a mop over the duodenum, over the transverse colon there. So the retractor, you retract, then you look, there is a gallbladder. So how can you remove the gallbladder? The gallbladder, first thing you assess, your anatomical knowledge, recapitulate. The anatomical knowledge is the gallbladder is attached with the common bile duct, common hepatic duct. So you need to disconnect from the common hepatic duct, one. And there is a connection with the arterial supply. So that arterial supply is the cystic artery, which lies in the callous triangle that needed to divide. Cystic artery, which lies in the callous triangle, which also needs to divide. Cystic artery. So cystic artery, cystic duct is divided. Then the gallbladder is attached only with the liver bed by the peritoneal reflection, which is sometimes called cholecystohepatic ligament. So remove it out from the gallbladder fossa by blunt and sharp dissection. Remove it out from the abdominal cavity to the exterior to the trolley. Then you assess, is there any bleeding from the liver bed? Is there any bleeding from the cystic artery? Then confirm it, hemostasis it. After confirmation, we usually put a drain inside the peritoneal cavity, then close the muscles as you open as you like. Then the open cholecystectomy is completed. So this is about the open cholecystectomy. What about the laparoscopic cholecystectomy? So the anesthesia is the same, general anesthesia. In case of open cholecystectomy, there is a incision, big incision from the midline to the exterior, about 6 centimeter, 8 centimeter, 10 centimeter. It is variable in size, but here only the holes can done the surgery very precisely and very short timely. Very cosmetically effective surgery can done by laparoscopy. So that laparoscopy method sometimes asked in the exam. First thing is, during laparoscopic surgery, how many ports made for cholecystectomy? The answer is 4 in number. Ports means the hole. So access to pathway. So access to the abdomen by 1, 2, 3, 4. So first answer is, how many ports? 4 ports. 1. Second question sometimes asked in the exam, what is the size of the port in the umbilical area? Your answer is 10 millimeter umbilical port. 10 to 11. Sometimes in the written 11, so 10. So it is 10. The other ports are, in the epigastric port, it is 10. Rest of the 2 is a 5 millimeter port. Rest of the 2 are the 5 millimeter port. So this is the basic questions asked sometimes in the exam, because this question asks for that reason you are seeing the laparoscopy or not. This question is tested your student quality. If you are a good student, if you attend the operation theater, you can monitor that 4 ports, you look or not. If you look, you can easily give the answer. For that reason, that question is asked in the exam. How many ports? 4 ports. What is the size of the ports in the epigastric? 10 millimeter. What is the size of the port of the umbilical? It is 10 millimeter. Rest of the 2 ports are 5 millimeter. Then sometimes asked in the exam, what is the camera port? That means illumination port. It is always the camera port is umbilical one. Because through the umbilicus, the port, that is the camera port, because at the center of the working within the field of the vision. For that, if you place a camera there, the field is not at the center. So if it is there, so directly can visualize that area, the camera at the center. And that 2 ports, upper 2, epigastric and right hypochondria port, is the working port. And the right iliac fossa port, it is for retraction of the gallbladder. That means that port, the forceps is placed there, hold the fundus and retract the gallbladder up so easily can delineate the callus triangle. For that reason, the fundus is held up by the right electro support. The dissection, cutting, all the things done with the clipping by the two ports. On the right, epigastric port is the working ports, and hypochondriac port is the working ports. That two forceps is needed. Port is needed for the working the surgery. For that reason, it is called the working channel for surgery. So that thing is asked in the exam. That's all the terminology everybody must know, because lot of questions asked from that pages only. The other thing is the method of laparoscopy one. That means we make a hole at the umbilicus or the supraumbilical or the infraumbilical regions. That hole, put a trocar there, and through that trocar put a gas pipeline. So that gas pipeline can inflate the abdomen. That means whenever the gas is introduced through the trocar, the abdominal wall become far away from the entry wall, is far away from the viscera. So all the viscera are dropped on the posterior wall. So there is a wide gap between the parietal wall and the viscera. So you can easily look all the structures there. For that reason, the gas is inflated. In the exam, sometimes asked in the exam, what is the name of the gas inflate? The answer is the gas is carbon dioxide. Then the question is asked, why not oxygen? Why not nitrogen? Why nitrous oxide? Why you inflate the carbon dioxide? The answer is, we use during cholecystectomy we use some diathermy, so which causing some heat there, some electrical combustion there. So it may become combustion. That means there is more flare of the fire inside the abdomen, and oxygen helps for burning the tissues. So if you give the carbon dioxide, there is no fire, there is no combustion. So for that it is safe, one thing. Another thing is the carbon dioxide having a capacity, the quality is it can easily diffusible through the membrane to the vessels and easily excretable from the lungs to the exterior. During cholecystectomy, whenever the abdominal wall is distended, by abdominal cavity is distended with the carbon dioxide to some extent absorbed with the surface epithelium, with the blood vessels from the absorption. That absorbed carbon dioxide is expelled out by the lung. For that reason, the anesthesiologist during cholecystectomy, they can more contract the bag, so there is more respiration, more expel out of the carbon dioxide from the lungs to the exterior. So which are the carbon dioxide which is absorbed, it can easily expel out through the lungs. For that reason, that question is asked. And another thing is, after inflation of the abdomen, then examine where the gallbladder is, what the condition of the gallbladder is. Then you plan and go for surgery. So the advantage is, it is less post-body pain because there is a less cut, small hole there for that reason, one. So less post-body pain, and there is a chance of wound infection less, reduction in wound infection, dehiscence, bleeding, herniation, nerve entrapment, etc. Improved vision because we look the inside with a telescope, which is 10 times magnification from the normal one. And better cosmesis after removing the trocar. There is a small teeny hole in a scattered fashion in various areas. So there is a very small teeny scar and better cosmesis. Improved mobility because there is less pain. So early capable to move the patient from the bed, and early discharge hospital, short stay hospital, early return to normal physiological life, and early resumption for normal activities. So these are about the cholecystectomy. What about the cholecystectomy complications? So every operations there is having to some extent of complications. Somebody have more, somebody have less. So without complication, no surgeon is available in the world. Not all the patient, any patient may develop by any surgeons anytime. So for that reason, the complications, if you don't know, you don't cautious during surgery. If you know the complications, so during surgery, you be more meticulous, more cautious, more do the surgery. For that reason, there is an injury. That means injury to the common bile duct, common hepatic duct, duodenum, right hepatic artery. The surrounding structures are very close to each other. So there is every possibilities of injuries there. And important thing it is, you do the surgery during the time, operation time, you look, there is more hemorrhage there. Or after operation, recover the patient, discharge the patient from the hospital, operation theater to the post-operative ward, and there is a chance of hemorrhage maybe. That hemorrhage may due to the slippage of cystic artery. The artery which you ligated, it becomes slipped during post-operative period, and there is profuse hemorrhage may happen. And there may be a accidental ligation of the CBD during surgery. Mistakenly, you don't diagnose the cystic duct. You may diagnose the CBD is a cystic duct, make a clip there and cut it there. So you don't know and put it there as it is a clip there. So subsequently there is a biliary stricture and obstructive jaundice. And there may be a retained stone in the CBD. Or during manipulation, the cystic duct, through the cystic duct, the gallstone may migrate to the common bile duct. And you do the surgery. So there is some residual collection inside the abdominal cavity. It becomes infected. They presented as a residual abscess. We are always cautious about the drain tubes in the postoperative period, particularly in the biliary surgery. In the next morning, we look about the content of the drain bag. What is the color of the drain is. If it is a serosanguinous to some extent, so don't worry about it. Yeah, but if there is a biliary contents, bile is coming through the drain tubes. So we are worried about from where the bile came. It is from the cystic artery. It may be from the accessory cholecystoid hepatic duct, or it may be injured from the common hepatic duct. Anywhere there is chance of bile is coming there. So at that time we are more alert and follow up the patient. So what thing happened there? So bile is an irritant, is dangerous for the patient because that if it is a massive amount of bile leak there, so the bile is migrated throughout the peritoneal cavity, there is generalized peritonitis develops, the abdomen becomes distended, the patient is icteric, and the patient may die if you don't treat or intervention done earlier. So for that reason, biliary peritonitis is dangerous for the patient and for the surgeon also. And another important thing is, there is sometimes some written in the books, there is one syndrome, it's called the Waltman-Walter syndrome. It is a very interesting terminology. If you know the pathogenesis, you can remember the terminology the syndrome is. That means whenever the bile is leaked from the biliary tree, it is accommodated into the subhepatic space. When the subhepatic space is full, then the bile is migrated up into the undersurface of the diaphragm. So when the undersurface diaphragm is full, so the pressure given over the liver. So the liver is dropped down to some extent. So that drop down causing some impairment of the venous return because the liver, right over the liver, in the posteriorly, the inferior vena cava within the liver. So whenever the liver is pushed down, so there is a kinking of the vena cava at the level of the diaphragm. So there is a decreased input of the cardiac input through the vena cava. So there is a decreased cardiac output. So the decreased cardiac output causing the pain in the chest due to the ischemia of the heart. So the patient presented as a heart pain, that means chest pain. So that chest pain, it is not due to the heart disease, that is secondary to the effect of the intraperitoneal collection. This syndrome is called the Waltman-Walter syndrome. So if you know the pathogenesis, you can easily remember what is the Waltman-Walter syndrome. So it is not required for your level. but only for your interest to know the pathogenesis, which is required subsequently whenever you go for post-graduation in surgery. In that time, it is needed. So this is about the laparoscopic cholecystectomy, some steps of procedure. That video is the supraumbilical one. But initially, whenever starting the laparoscopic cholecystectomy, the first port is made through the umbilicus, so which is called the transumbilical port. So at that time, they are chosen that with the aim of it is the thinnest part of the abdominal wall. There is a scar and nothing more muscle is there, so easily can pierce. So that transumbilical port is chosen in the earlier in the period. But nowadays, some surgeons choose in the supraumbilical port, some surgeons choose in the infraumbilical port. It depends upon the surgeons. But for your examination, your answer is transumbilical port. So first, there is two types of port. One is open port, another is blind port. So the basic difference is, in case of open port, you just first hold up the muscle skin with the two Cocker's forceps, make an incision with a knife. Then the blunt dissection, the lumen is open up. Then introduce the trocar. In case of blind procedure, you make a small hole there, incision over the skin, then put a Barrett's needle. It is a specialized needle. There is a tip. The tip is whenever you press, it becomes sharp. Whenever pressure is released, it becomes blunt. There is a two part. So the blunt part is open up when the pressure is released. So the Barrett's needle is introduced inside the abdomen. The gas is connected. So then the inflation of the abdomen with the carbon dioxide gas, the abdomen is distended. Then that Barrett's needle is removed. Then put a 10mm trocar through the incision to the abdomen. So whenever the wall is distended, abdominal wall is distended, so there is less chance of visceral injury. For that reason, first inflate the abdomen with the Barrett's needle, then put the trocar, and after introduce the first trocar, so you are safe enough. You can look all the abdominal viscera and other ports with direct visualization with the port. So look, there is the first port is
created for the laparoscope. 3 more incisions will be made with care taken to keep the openings as small as possible. Once in place, the laparoscope will provide video images that allow the surgeon to locate and pull back both the liver and gallbladder. Next, the surgeon removes the connecting tissue in.
So look, the gallbladder is attached to the liver. It is covered with the peritoneal reflections. So first, the peritoneal reflection is open up. Otherwise, you don't visualize the cystic artery and cystic duct there. So for that, first open the peritoneal reflection anteriorly. So look, there is artery, there is a duct.
In order to expose the cystic duct and cystic artery. Using clips, the surgical team clamps off both the duct and the artery, which are later cut to prepare the gallbladder for removal.
So look, the artery and duct are clipped on the both sides, then divided. And after that, the gallbladder is removed from the gallbladder, only the peritoneal reflection is there. So during that time, you look, there is a gap, and that two gap is seen only between the liver and the cystic duct, only the cystic artery is there. This is called the critical view of safety. So that critical view of safety needs to take images for documentation, so there is no accident during the time of surgery. It is documented.
Finally, any remaining tissue connecting the gallbladder to the liver is cut. The gallbladder is moved into the laparoscopic working port, where it is taken out of the body.
So gallbladder is delivered either through the epigastric port or through the umbilical port. If your gallbladder is delivered through the umbilical port, the camera is shifted to the epigastric port for visualization of the umbilical port, and then pull it out with the retrieval bag or a direct one. If you suspected that the patient having malignancy, always you put a bag, or within the bag the gallbladder remains there and remove it out for prevention of metastasis at the port site. Or there is infection mode, it is better to remove the gallbladder with a retrieval pack. So acalculous cholecystitis is important needs to evaluation. Very important thing. The acalculous one is more dangerous than the calculous cholecystitis because whenever there is a stone in the ultrasonography, everybody can orient it. They are more interested to remove the stones from the body to the exterior. For that reason, acalculous cholecystitis decision making is very difficult. So acute and chronic acalculous cholecystitis can occur in absence of stones, give rise to clinical features similar to the calculous cholecystitis. And precipitating factors for a development of acalculous cholecystitis are critical ill patient, major surgery, trauma, burn that may predispose to acute acalculous cholecystitis, immunocompromised patient may develop acalculous cholecystitis, dialysis patient, typhoid fever. It is very important thing. In case of chronic carrier, prophylactically needs to do for cholecystectomy. In diabetic patient, there is chance of acalculous cholecystitis more. So acalculous cholecystitis, this is termed as a cholecystosis. These are the group of conditions affecting the gallbladder in which there are chronic inflammatory changes with hyperplasia of all the tissue elements. That means cholesterosis, which is called the strawberry gallbladder. It looks like a strawberry. The interior of the gallbladder, whenever open up, looks like a strawberry. There is a yellowish area of submucous cholesterol depositions. And cholesterol polyposis, that means cholesterol laden polypoid projections in the mucosa. And cholecystitis glandularis proliferans, that means granulomatous thickening and hyperplasia of the gallbladder wall. And another one is diverticulosis of the gallbladder. These all are called cholecystosis. So this is the mucosal of the gallbladder. The mucosal can diagnose very easily. If you place in front of the light can pass from through and through, and the content is mucus, white, transparent. So pathogenesis mucus I described is previously. This is very important thing is obstruction of the cystic duct due to the stone or neoplasm. Be careful about it. Not only the stone, it may, if there is a growth in the neck of the gallbladder, it may obstruct the lumen. So failure to drainage the bile to the cystic duct, absorption of water and water soluble contents of the bile, and hypersecretion of mucus from the mucous membrane, excessive accumulation of mucus within the gallbladder, distension of the gallbladder, mucosal of the gallbladder. So that mucosal is a painless swelling, an important thing it is. Right hypochondria, non-tender, smooth, soft, globular, palpable gallbladder, it is important thing. By your palpation, it can easily diagnosed the area of the gallbladder. There is a smooth piriform shape, that means pear-shaped masses moves with the respirations, and features of dyspepsia. And complication, if infected, causing empyema gallbladder, it may rupture. It is very rare, causing the pseudomyxoma peritoni. And treatment is a cholecystectomy. So this is, look, the pass inside the gallbladder is called the empyema gallbladder. And empyema gallbladder, it is same, the sequelae of acute cholecystitis may turn with the empyema gallbladder, or pre-existing mucosal may infected may turn with the empyema gallbladder. It can perforate and can cause peritonitis. It is very, in case of acalculous cholecystitis, there is chance of perforations, gangrene of the wall and perforation and causing generalized peritonitis. It is the diagnosis in fever whenever the patient high fever, chill and rigor, toxicity, pain, tenderness, etc. And investigation can dictate that the patient having an ultrasonography can easily diagnose the patient having a thick sludge inside the abdomen, and the wall is thick and edematous, and total count is raised. So the treatment is the complete bed rest, nothing about nasogastric tubes, IV fluids, broad-spectrum antibiotics, analgesics, and treatment is cholecystectomy. If the cholecystectomy is not possible because there is a more dense adhesion there, in that case you just go for the cholecystostomy. Just drain the gallbladder with a Foley catheter, and after declining the infection, subsiding the infection, subsequently you can go for after 3 to 6 weeks. After the 6 weeks or 8 weeks, you go for the cholecystectomy. So it is a very important thing. It is a gallstone ileus. Always remember it is. Look, there is a gallbladder. So the gallbladder, whenever the stone is big stone there, so it is heavier. It rests upon the duodenum. So whenever there is a rest upon the duodenum, subsequently the stone is eroded the muscle wall. Gallbladder wall is eroded. Ultimately the duodenum wall is eroded, and ultimately the gallbladder stone is dislodged to the duodenum and passing down go to the ileum. It may causing that stone go into the ileum and causing the intestinal obstruction. Sometimes the gallbladder rests upon the antrum of the gallbladder and there is a protruded mucous muscle cord is eroded, muscle cord of the stomach is eroded. Under the mucous membrane, if you do an endoscopy, there is a protrusion like a polyp inside the stomach maybe. And subsequently is untreated, the stone is dislodged in the stomach causing cholecystogastric fistula. But commonly in the cholecystoduodenal, or it may go into the cholecystocolic fistula because the transmuscular lies there. There is transmuscular lies there. So it is a type of the acute intestinal obstruction often seen in elderly due to the blockage of the bolus or mass of the gallstone, which commonly enters into the intestine through the cholecystoduodenal fistula. But that fistula and obstruction having some special criteria, the stone size must be 2.5 centimeter. Otherwise, it does not produce any intestinal obstruction symptoms. And ultimately, the blocks narrow part of the ileum, that means the area where the Makers diverticulum lies, that means 60 centimeter proximal to the ileocecal junction, it is the commonest signs of gallstone ileus obstruction develop. So the clinical presentation are the same. In the X-ray, plain X-ray sometimes detected, if you very carefully look, there is a stone in the gallbladder and there is a calcified shadow there, which may be intestinal obstruction along with maybe there is a gallstone ileus. This is the intestinal obstruction due to the gallstone ileus. So how you diagnose a gallstone ileus? A plain X-ray you can assume. And another one is a CT scan. This is one of the patient of me. That patient present to me with acute intestinal obstructions. I do a CT scan. This is the report given there. So this is the gallbladder. So there is a stone, and this is the intestine lumen where there is a stone, and the gallbladder. The information can easily be written there. The normal in size, wall is mildly thickened, multiple dense structures within the gallbladder lumen. Air is seen in the gallbladder lumen. It is a very important thing is in the gallbladder lumen. Whenever there is stone and there is intestine, there is a stone calcified shadow. So if there is a stone along with gas there, so it indicates that there is some communication with the GI tract. So the gas can dictate that the patient having a cholecystoduodenal or cholecystocolic fistula. If there is a cholecystocolic fistula, it does not produce gallstone ileus. But if it is developed in the cholecystoduodenal fistula, so there is chance of gallstone ileus. So in the written, there is directly given the impression. Cholelithiasis, cholecystitis, cholecystoenteric fistula, dense structure within the ileum, mildly distended, small bowel loops with interperitoneal collection. So this is the diagnostic features of gallstone ileus. So these are the treatment of the gallstone ileus. That means you remove the gallbladder, you need to remove the gallbladder, and the first choice is not to remove the gallbladder. Your first impression is to relieve the obstructive symptom. You do a laparotomy and go to the site of obstructions. If the stone is friable, soft, then you can milk it and broken it and okay. But if there is a hard stone, it is not capable to broken down. So in that case, do an enterotomy and remove the stones. And if the patient is feasible, at the same sitting, go for the cholecystectomy. If the patient is not feasible enough to general condition, you don't go the operation at the same time. Later period, you can go for after 6 weeks or 12 months, 12 weeks, you can go for the cholecystectomy. So this is important one of the Meiji syndrome. Sometimes present in the short note in the exam, Meiji syndrome. That means the stone impacted in the neck of the gallbladder. So that no neck stone impacted, causing a pressure effect over the common hepatic duct. So look, the common hepatic duct above is dilated, the lower is not too much dilated. So in a normal individual, it is same caliber almost. Common hepatic and common bile to some extent is smaller in comparison to common bile duct. But here, the lumen is compressed with the stone, with the wall. That means the stone causing inflammation. So inflammation is chronic inflammation there. So the deposition of collagen tissue, it becomes thickened and it causing pressure effect there. It is called the Meiji syndrome. That stone ultimately eroded the muscle coat of the gallbladder neck, then the common hepatic duct, then the stone is migrated there. So it may causing there is complete obstructions and causing jaundice, obstructive jaundice. So this is the types is clarified by the involvement of the stones in the common hepatic relations. So there is a lot of types is written in the Indian books, but for your level, you only need two things. One is, if the stone is impacted there, it make a pressure effect over the common hepatic duct, so it is called the narrowing of the lumen. It is called the type 1. Whenever the stone is to some extent is eroded and go into the lumen of the common hepatic duct, then it is called type 2. So the type 2 is clarified when 1/3 of the circumference is involved. When 2/3 involved, it is called a type 3. When the whole thickness is involved, it is called a type 4. And in the book written in the new Indian book, Miriji, it is a 2008 edition probably, but it is not for your level needed. Your level up to 1 and 2, this is 2 is sufficient for you. So the treatment, how you done the treatment? The treatment, you need to remove the gallbladder. Okay, you needs to remove the gallbladder. So whenever you cut his hair and remove the gallbladder stones, so the lumen is open up. Then you can repair the wall, or you make a T-tube there and pull it out. So put a T-tube, and subsequently there is a scar and the wound become healed up. And we get tract. The tract, when remove the tract from the gallbladder, the T-tube, the tract is occluded, the patient is okay. So far we discussed about the gallstone disease. But important thing it is, the Miriji syndrome is suspected on CT scan. It is very important thing it is, but easily identified on table. Because we routinely don't go for CT scan. So if you do a CT scan, then you can more easily delineate the patient having Miriji syndrome or not. So that pressure effect causing some jaundice patient. So it needs to cholecystectomy, on table cholangiogram, and exploration of the CBD, and if it often needs cholecystocogenostomy. In that case, a T-tube, you can put a T-tube and close it out, or you make a bypass over the broad end of the opening there. That means you cholecystocogenostomy. Rho and Y, cholecystocogenostomy. So this is about the discussion, all the things about the gallstone. So far the discussion is more elaborate because it is needed, because most of the long cases in the exam are the gallstone disease. In the written, in the long case, so everybody must in and out all the things of gallstone disease must be read from the book. So thank you for elaborate discussion and take the time to know the discussion. So now the session is open for question and answer session. Do you have any question to ask now?
Hello, sir.
Yes.
Assalamualaikum, sir.
Aslam.
Sir, is MRI useful in detecting the gallstones?
Yes, MRI usually we prescribe those individuals who having a stone in the common bile duct. For detection of the common bile duct stone, the MRI is indicated. The name of the MRI is called the MRCP, magnetic resonance cholangiopancreatography. So whenever we suspect that the patient having a common bile duct dilated or not dilated, there is a stone in the common bile duct, in that cases we do the MRCP. Otherwise, for the gallstone diagnosis, we don't go for MRI. Because
Thank you, sir.
the MRI advantage is the MRI does not need any contrast. Only there is you put the patient under the MRI machine, and it takes time, long time required to visualize the biliary tree. That they reconstruct the common bile duct biliary tree along with the pancreatic duct, and you can easily delineate how far the dilatation is, and you can delineate the biliary tree structures, the 3D reconstruction there. For that, an MRI is done in case of common bile duct stone or intrahepatic duct stones. So, any more questions?
Thank you.
Thank you. Any more? So, if there is no more, you read from the books. Tomorrow, from the books, you read. and you can clear all the conceptions from query. And if any more, you can make an email or the message. Then we can discuss on the day after tomorrow discussion. Day after tomorrow, we can discuss about the obstetric journeys. So thank you for patient sharing. Thank you, everybody.
Thank you, sir.